Welcome to Bullet Point Nursing. In this video, we're going to go through the neurological system for the Adult Health or Med-Surg nursing course. And of course, if you're here for the NCLEX review, that's going to work as well. So let's go through so that you're really well prepared for class. First, let's start with anatomy and physiology. Just a quick refresher, we'll go through this section pretty quick. The primary function of the nervous system is to control most of the other functions in the rest of the body. For example, the brain is not responsible for moving air in and out of our lungs. The lungs do that, but the brain controls that. So that's the overall function of the nervous system, of the neurological system. There's a bunch of different parts of the nervous system, so let's go through it. First, we have the central nervous system and the peripheral nervous system. The central nervous system includes the brain and the spinal cord. The peripheral nervous system includes the cranial nerves, the spinal nerves, and the autonomic nervous system. The autonomic nervous system has two parts that you're probably familiar with, the sympathetic and parasympathetic systems. Sympathetic is fight or flight, parasympathetic is rest and digest. Next, let's talk about the meninges. The meninges are a protective coating that sits between our brain and the skull, and it serves a few different purposes. First of all, there's three different layers. There's the dura mater, the arachnoid mater, and the pia mater. These three layers are called the meninges, and these act to protect the brain. They also act to cushion the brain, and they also have some functions of maintaining chemical stability within the brain itself. Now, then we have the cerebrum. The cerebrum is what most of us think of as the classic. When we say the brain, we're usually talking about the cerebrum. The cerebrum is responsible for many of our higher functions. The frontal part of the cerebrum is responsible for motor and speech and executive function. The parietal part of the brain is responsible, of the cerebrum specifically, is responsible for sensation. The temporal, that's going to be the sides, that's responsible for hearing and memory and language. And then occipital, which is the back of the cerebrum, is responsible for vision. Next, we have the cerebellum. Students often confuse these. The cerebellum is responsible for coordination and balance. Next, we have the brainstem. The brainstem includes the midbrain, the pons, the medulla, and this regulates much of our vital functions such as breathing. And then finally, we have the spinal cord that's responsible for getting messages to the brain, out from the brain to the rest of the body, and from the body back up to the brain. Next, let's talk about a little bit more of the nursing stuff, and let's talk about the different assessments that we're going to do for a patient having a neurological issue. First, we have to understand level of consciousness. If you remember ABCs, ABCD, airway, breathing, circulation, D at the end of that stands for disability, which is a neurological assessment. The most used neurological assessment in trauma, in ER, in ICUs is the GCS, the Glasgow Coma Score. We have a separate video on that if you want to really go through it, but the GCS, Glasgow Coma Score, or Glasgow Coma Scale, depending what book you look at, gives a patient a score from 3, being completely unresponsive, no movement, no anything whatsoever, to 15, and it checks 3 different things. It checks your eyes, and that checks whether you are completely responsive, responsive only to verbal, responsive only to pain, or completely unresponsive. Then, and it gives you a score 1 through 4, that's called the AVPU score, Alert, Verbal, Pain Oriented, AVPU. That would be 1 through 4, 1 being nothing, 4 being fully alert and oriented. Next, we have the verbal. And this is what we're familiar with as, are they oriented, alert and oriented? So first we checked if they're alert. Now we're checking if they're oriented. Oriented, again, goes 1 through 5 this time. So 1 is going to be completely nonverbal, and 5 is going to be fully alert, oriented, able to answer all questions. And then finally, the last section is going to be motor, and that's going to be no motor response whatsoever, which will be a 1, or completely able to follow all commands. That's going to be a 6. So the highest you could get is 4, 5, 6, which is 15. The lowest you could get is a 1, 1, 1. Glasgow Coma Score is a key part of neurology and neurological assessment. It's probably the most tested on neurology assessment. Next, let's look at the pupils. I want to be clear on something. Anytime you're assessing a patient for a neurocheck, if let's say the doctor ordered neurocheck Q15 or Q hour or Q4 hours, you're always going to be including the GCS, you're going to be including the pupils, you're going to be including their motor and sensation in their extremities, plus a good rule of thumb is to always include the vitals as well. Let's move on to pupils. Pupils, we're going to check if they're PERLA, pupils equal, round, or light to accommodation. One thing that I do have to point out, because this is commonly tested on in neurology, is the concept of a blown pupil. If you ever hear of that, that's where a single pupil is blown, meaning it's completely dilated, and it's fixed. The more correct medical term is fixed and dilated. The slang for that is a blown pupil. Fixed and dilated is a really, really bad sign. If it's on one side of the brain, or if it's on one side in one pupil or in both, either way, it's a bad sign. But you could have, let's say, the left pupil's fixed and dilated, or the left pupil's blown, or you could have both pupils fixed and dilated bilaterally. That's usually a dead person. Moving on, we have motor and sensation. I'm not going to go too deep into that. We have other videos where we cover a motor assessment and a sensation assessment. Basically, you're checking in the 4 extremities. Is the patient able to move all extremities? And the patient do they have sensation in all extremities? We're also going to assess their reflexes, their deep tendon reflexes, make sure those are intact. That's part of a neurology assessment. That might not be as common to do as part of just a standard every hour or so neuro check. That doesn't always include reflexes. Speech and language, that would be if they're having some sort of specific issue. Most commonly, that comes to mind for a stroke, where we check if the patient has any slurred speech, if they have aphasia or dysarthria, unable to speak, or a difficulty getting out words. Cognition, this is the alert and oriented. Do they have good recall, good memory? There's lots of different tests out there that we use to test the patient's memory, and cognition, and depending whether we're looking at it from a psychiatric perspective, from a cognitive perspective, a neurological perspective, there's lots of different ones, but cognition is assessing their orientation, their memory, their judgment, their awareness of what's going on. Cranial nerves, I'm sure you've learned that in the past already, but we have 1 through 12 on the cranial nerves, and that might be done as part of a comprehensive neuro exam that wouldn't be part of your basic neuro checks that you would do on a regular basis. Finally, vital signs. When we talk about vital signs, first of all, we talk about, in neurology world, we include intracranial pressure, not really as a vital sign, but as a vital sign, meaning not one of the official 6 vital signs, but something that's very vital for the RN to be assessing. Intracranial pressure, we'll talk more about that in just a minute. And then we have Cushing's triad. Cushing's triad is very much tested on in RN neurology. And Cushing's triad is a sign of increased intracranial pressure. That's what we just talked about. Increased intracranial pressure can lead to herniation and other things, and we'll get more into that in just a few minutes. But Cushing's triad is a classic assessment tool used in neurology that's often tested on. And what is it? It's 3 things that are a sign of increased intracranial pressure. The 3 things are hypertension, specifically where the systolic goes up and the diastolic either doesn't or goes down, meaning that the difference between a systolic and a diastolic gets bigger and bigger. It's called a widening pulse pressure. That, along with bradycardia and irregular respirations, such as Cheyne-Stokes respirations, would be your classic Cushing's triad. If you ever see a question where the patient has that widening pulse pressure, that's really the only thing that the test is going for, is Cushing's. And with Cushing's, we're going for increased intracranial pressure. And with increased intracranial pressure, we'll learn in a second, we're going towards herniation, which is a really bad outcome that leads to death. But again, widening pulse pressure, definitely mark that down somewhere as Cushing's triad and a sign of increased ICP. Next, let's look at some of the diagnostics that we use to assess for a neurology patient. A CAT scan, also known as a head CT, is going to be the bread and butter of neurology imaging, because that's the most common test that we do for neurology imaging. That's going to be a head CT. That could be with contrast or without contrast, but that's going to be our go-to test. We use it for a patient reporting worst headache of their life, any suspected stroke, any suspected head trauma, anything like that. Always getting that head CT. Next, we have an MRI. This is more detailed. This is to check for things like cancer, multiple sclerosis, different things. We could also use it if a patient's having certain types of a stroke. We would do this as a follow-up assessment after we've already gotten the head CT. A CTA, cerebral angiogram, is where we get imaging of the cerebral blood vessels. This isn't really something we do very often in the acute setting for trauma, but we might do this for other things where we suspect that there's some sort of cardiac issue going on in the brain, not cardiac meaning heart, but cardiovascular meaning the vessels. Next, we have EEG, or electroencephalogram. This checks the electrical activity of the brain. We use this most commonly for seizures, and this is what an EKG is to the heart. The EEG is to the brain. And finally, we have ICP monitoring. ICP monitoring is going to be very important in a patient that it has or is at risk for increased intracranial pressure. The normal, and you do need to know this for testing purposes, is 5 to 15 millimeters of mercury. That's what a normal intracranial pressure should be. And if that starts going up, if that gets up to 20, 25, 30, that patient's at extremely high risk of herniation. Herniation is where the brain actually gets pushed down through the opening in the skull, and that patient very often dies very shortly thereafter. Let's go through some quick notes, and then we get into the second half of the lecture with going through the actual diseases. The first note I have here is the head of the bed should be elevated. In any patient that's a neurology patient, if they're having a stroke, trauma, anything to do with increased intracranial pressure, we always want the head of the bed elevated, and that's to use gravity to at least lower some of that swelling or whatever it is that's causing that increased ICP to get some of it out of the skull. So that's why we want the head of the bed elevated, 30 to 45 degrees. I've seen it both ways, but more common is to say 30 for test purposes. Next, you need to know what seizure precautions are. Any patient who is having a seizure, diagnosed with a seizure, or at risk of having a seizure, such as they have, let's say, a really low sodium level, the doctor may order the patient to be put on seizure precautions, or sometimes you can initiate this even without doctor's orders. What is that? First of all, it's making sure we have suction available. It's making sure that the patient's area is safe so that they don't come to any harm by objects around them, nothing with them in the bed. We're also going to make sure that they have padded rails. They make special pads that Velcro onto the rails, and that's by far the most common thing that we would test on as far as what are seizure precautions. I will also elaborate here just a little bit. If a patient does have a seizure and they're not in bed, please move everything away from them. We'll talk in just a few minutes about seizures. But in case I forget to mention, then also make sure you don't restrain the patient. You don't put anything in their mouth. Just move everything away that they can't get hurt. If they're standing, gently lower them to the ground to prevent any injury. Yes, you can do that while they're seizing if necessary. Next, we have neuro checks. Like we talked about this already. This is where we're constantly monitoring their pupils, their level of consciousness, usually a full GCS, their motor and sensation, as well as vitals. Depending what's going on with them, we may be assessing some of the other stuff that we talked about earlier, such as their intracranial pressure. Finally, increased intracranial pressure. That's a secondary complication. No one walks into the hospital and is diagnosed with high ICP. That's something that comes from a stroke, from encephalopathy, from any one of a bunch of different pathologies, both medical and trauma, that can cause that high ICP. But that's generally speaking, it's a secondary complication. It's never a primary diagnosis. Next, let's talk about autonomic dysreflexia. This is very commonly tested on, and it's actually pretty interesting. And the reason this is tested on, because this is actually a nursing intervention to fix it, which is pretty cool. So autonomic dysreflexia is what? It's where a patient who has a spinal cord injury, usually T6 and above, where they suddenly become hypertensive, like extremely hypertensive, 160, 170, 180, 200 and plus. Those patients, when a patient has autonomic dysreflexia, it's stimulated by something that's pissing the patient off, some annoying stimuli. The most common things that you'll see on tests that I've seen in the different nursing test banks are questions such as the patient has a spinal cord injury, has high blood pressure. What would be an appropriate nursing intervention? So some things would be check for a full bladder, because that's one of the most commonly tested on causes of autonomic dysreflexia. Another really common one is check for some object in the bed with the patient that's making them uncomfortable, because even though they have a T6 injury, they could still have sensation. And if they have, let's say, a roll of gauze under them that's making them uncomfortable, that can cause this autonomic dysreflexia. So just write down in your notes for testing purposes, always look for what is causing it, because a nursing intervention usually to get rid of whatever it is that's making them uncomfortable. Obviously, if it's something like a full bladder, then that would be dealing with a Foley, which if they don't already have is something you'd have to get orders for in most cases, not always. Let's move on to GBS, Guillain-Barré syndrome. This is really a disease. It's an actual disease. I didn't put it with the full diseases where we go into full depth on those, because I just sort of want to go through this quickly. There's really only two commonly tested on questions about this, so I'm going to cover both of those, but I don't think this is going to get the full deep patho and diagnostics and everything that we're going to go through with the other diseases. So Guillain-Barré syndrome is almost always a secondary condition that develops after a patient has a viral infection. That's the most common presentation. And this, what it actually is, it's demyelination of the peripheral nerves. It's where the myelin sheath that surrounds the peripheral nerves starts to come apart, which is a really big deal. This takes weeks to months to years, a year or two sometimes, to completely recover from, assuming the patient makes a full recovery, which most patients do. And the classic question about this is both on its presentation, but specifically the fact that its presentation includes ascending weakness. It starts in the feet and the legs, and it works its way up. And it puts the patient at risk if it keeps working its way up to the hips, the abdomen. If it gets to the chest, then the patient's at risk for respiratory compromise, because that ascending weakness can weaken the diaphragm and they stop breathing. So again, the things to know about this, it's a follow-up disease to viruses. Most commonly, it's a demyelination of the peripheral nerves. And that really common test question is that it's ascending paralysis, and the high priority nursing action is to watch their respiration so that it doesn't become compromised. Now let's get into the actual bread and butter of med-surg nursing, and let's go through a bunch of the different diseases that you're going to learn about in class. So first, let's start with a stroke, also known as a cerebral vascular accident or CVA. So what is a stroke? Well, that depends because there's two different types. One is called an ischemic stroke, and an ischemic stroke, which is by far the most common stroke, 80 to 90% of all strokes are ischemic. That's where the patient gets a blood clot in one of the cerebral arteries. So now part of the brain is no longer getting perfused. That's an ischemic stroke. The other type of stroke is a hemorrhagic stroke, where one of the blood vessels in the brain bursts, and now the patient's bleeding into their brain. That's much less common. That's about 10 to 20% of all strokes. How does a patient present? Well, a few things. First of all, they're going to have one-sided weakness, not bilateral. They're going to have one-sided weakness. So let's say they can't move they're going to have weakness in the right arm and the right leg, or just the right arm or just the right leg. That would be one thing. Another thing that's very common would be a facial droop. So one side of the face or the other, it has weakness. So the muscles are no longer getting well controlled. So they lose sensation. They just droop. That's going to be another classic sign. And then slurred speech would also be a very classic sign, or just difficulty speaking, difficulty finding words, dysarthria. These are all the classic signs of a patient having a stroke. Now, some schools I have seen, even at the RN level, they get into some of the details of what exactly would be the signs of a right stroke versus a left stroke. I'm not going to go into that. I think most schools would say that's beyond RN level, but you'll definitely see that. It's definitely in most of the nursing textbooks I looked at. But I just want to give you a heads up. You may need to be able to determine the difference between a right side stroke and a left side stroke. I'm not going to go into that in this video, but I will give you the most common tested on item in regards to that. And that is that if a patient's having a right-sided stroke, meaning the right side of the brain is affected, then you're going to see symptoms on the patient's left side facial droop, if the patient, one more time, if the patient's having a right-sided stroke, they're going to have left arm and left leg weakness, and same thing the other way. If the patient's having a left-sided stroke, they're going to have right arm and right leg weakness. So it's called contralateral. It's the opposite side of the body that's affected by the stroke. So just know that part, at least, to know the difference between a right and a left stroke. How is a stroke diagnosed? Two ways. One is every single patient who's suspected of having a stroke is going to get an NIHSS. What's that? That's the NIH, National Institute of Health, stroke scale. And this is a very detailed neurological exam. It goes through sensation, speech, repeating back to certain sentences. It's showing them diagrams and having them be able to describe the picture. There's a lot. It's a very detailed cognitive and neuromuscular exam that tells us a very detailed picture of what deficits the patient might have. That's the whole point of this, is to identify any neurological deficits that the patient has that could be linked to a stroke. And the second thing that we're always going to do every single time is get a head CT to see if we see the stroke. And obviously the only stroke we would see, at least in the acute phase, is a bleed. We wouldn't see an ischemic stroke, but by definition, if a patient has a NIHSS that's elevated and they're having an acute stroke that's going on this minute, if we don't see a head CT that shows a bleed, then that means it's not a bleed, that means it's the ischemic. How do we manage that? Again, it splits off between whether it's an ischemic stroke or a hemorrhagic stroke. If it's an ischemic stroke, meaning a blood clot, we give the patient thrombolytics. Those are known as clot-busting drugs. Those must be given within 3 to 4.5 hours of the onset of the patient having symptoms, which means you must, on your license, know when these symptoms began. And the only way to know that is to know 100% sure the last time the patient was seen perfectly well and normal. So if they say, well, I saw mom last night and this morning when I checked on her, she's having a problem, then we don't know when she was last normal other than last night. So the stroke could have been 5 minutes ago. It could have been 9 hours ago. The only thing we know is that 12 hours ago when her family spoke to her, she was fine. The other option we have is thrombectomy. Thrombectomy is sort of what we do for heart attacks, where we go in the cath lab and we deal with the clot that the patient has in their coronary arteries. Thrombectomy is where we go into a neurological cath lab, essentially is what it is, and we go into the brain arteries and we pull the clot out. The other option, if the patient, not other option, but the other type of stroke, if they're having a hemorrhagic stroke, then they may go ahead and get surgery. Next, we have anticoagulants. You have to know this for both ischemic and hemorrhagic. If the patient had an ischemic stroke, then they're going to get put on anticoagulants. If the patient is having a hemorrhagic stroke, then they're on an anticoagulant, they're going to be put on a reversal agent so that they don't continue to bleed. Make sure you're educating patients about these medications if they're put on them. Now let's go through a few of the most commonly tested on points with stroke. First of all, know what your FAST exam is. That stands for face, arm, speech, and time. And face meaning check for facial droop, arm check for arm droop or arm drift. S is check for speech, either difficulty speaking or slurred speech. And finally, T is know that time. NIHSS, we just talked about that. That's the stroke scale, the very detailed assessment to see if there's any deficits in the patient, in their neurological status. We're always going to check a sugar in any patient that we suspect of having neurological issue for the simple reason that a hypoglycemic patient, a low sugar, can have a lot of the same symptoms as a neurological patient. So we want to first make sure it's not the sugar before we go ahead and say that they're having a neurological emergency. And then finally, you may need to determine the difference between a right and a left-sided stroke. On any patient who's having a stroke, you can do frequent neuro assessments and make sure you include vitals, even though it's not technically part of it. You're going to avoid a rapid decrease in blood pressure. And there's a lot of different ways this could be tested on. First of all, a hemorrhagic stroke, those patients usually have a very high blood pressure and we need to bring it down. Secondly, if a patient has an ischemic stroke, they also very often have a high blood pressure, not as high usually. And that also we need to bring down in order to give them thrombolytics. In both of these cases, however, we do not crash their blood pressure. If they're sitting at 200 over 150, there's no way I'm bringing them straight down to 120 over 80. We have to do it slowly. Usually the rule of thumb is don't drop the blood pressure more than 25% within an hour ever. So if they came in at 200, the lowest I want it to be in 60 minutes from now is 150. That's 25%. There's no way I want it to be lower than that within that first hour. Finally, NPO. All patients that are diagnosed with a stroke are always going to be NPO. That means nothing by mouth. And that's going to be until they get what's called a swallow study. A swallow study is done by a speech-language pathologist in most cases. And it's where they assess the patient. They give them a little bit of a beverage to drink or a little bit of fluid. And they want to make sure that the fluid is still going down into the esophagus and not into the lungs. Because if the patient has lost control of that, of the epiglottis, that makes sure that where food and fluid goes is not into the lungs, is into the esophagus. If they've lost control of that, then anything they eat or drink is at very high risk of going to the lungs and causing aspiration and causing infection. So because we want to prevent that, all patients that have a stroke must have a swallow study done before they're allowed to eat or drink again. Finally, let's talk about a TIA. A TIA, or transient ischemic attack, is in slang terms called a mini stroke. And this is where they come in presenting exactly like a stroke, but they rapidly resolve, always within 24 hours, usually much quicker than that. And that's a TIA. A TIA puts them in the very high risk category for having a subsequent stroke. I don't remember the exact statistic, but it's something like 50% chance that they're going to have a stroke within the next 5 years or something like that. Really high chance that they're going to have a stroke. It's a really highly correlated risk factor with having a full-blown stroke. Next, let's move on to seizures. Probably the second biggest topic in neurology is going to be seizures. So seizure is where a patient has that abnormal, what we consider the abnormal jerking motion, but really let's go through the patho, because really it's all about uncontrolled electrical activity in the brain. So we usually see that manifested as the full classic seizure where the patient has that jerking motion, but really it's about what's going on in the brain, the uncontrolled electrical activity. There's three classic types of seizure. Generalized, that's where the patient has that full tonic-clonic is the older word for that, and that's where the patient has the full body doing the jerking motion, head, arms, legs, everything. Then we have partial or focal seizures. And those are usually used interchangeably. Partial focal seizures where it's only affecting, let's say, the right side or the right arm. And then we have absent seizures where they're having a seizure. They're having that uncontrolled electrical activity in the brain, but they have no outward signs of the fact that they're having a seizure other than the fact that their level of responsiveness is essentially going to be zero because their brain is not fully conscious. They're having a seizure. We just don't really see it. So those are different types of seizure. That's the path of a seizure. How does a seizure present? We already went through that. Different types have a different presentation. One thing we do need to know is about the aura and the postictal phase. Some patients will have an aura before having a seizure, and that is where they feel it coming on. And different patients will have different time frames of how much sort of heads up their body will give them of when this is happening. And the second thing to know is the postictal phase. Almost every patient that has a seizure is going to have a postictal phase that generally lasts 5 to 30 minutes. Now, within that time frame, they're going to slowly come back to full level of consciousness and being fully alert and oriented, but they're going to start usually very lethargic, very groggy, not really able to answer questions, not really knowing what's going on. And usually within about 5 to 30 minutes, they're going to come fully out of it, be fully alert oriented and able to follow commands. If that goes on for longer, then we have a problem. But a postictal phase is extremely common. In fact, that's the way most seizures present to the emergency department, because most seizures last roughly 2 to 5 minutes or less. In fact, most of them resolve in under 2 minutes, with or without medication, believe it or not. So most of the time when the patient has a seizure outside the hospital, by the time 911 brings them into the hospital, in almost all cases, the seizure is already over, and now they're in the postictal phase when they come into the hospital. How is this diagnosed? It's diagnosed by an EEG, electroencephalogram. We talked about that earlier, or possibly an MRI. Neither of these is actually necessary to diagnose a stroke. It's beyond the scope of this video, but usually this is not something that's diagnosed based on imaging. It's diagnosed based on presentation and history and exam. How do we manage a patient? First of all, if they have a seizure, if they're at risk of a seizure, the doctor's going to order seizure precautions, which you're going to have to follow. If the patient is actively seizing as we speak, we give them a benzodiazepine, usually lorazepam, which is Ativan. That's our go-to. We might also use diazepam, which is Valium, or we might use midazolam, which is Versed. Those are the three medications. Lorazepam, Ativan is by far the most common. If the patient has chronic seizure disorder, which is known as epilepsy, that patient will get put on a daily medication, which would usually be either phenytoin, carbamazepine, valproic acid, levetiracetam, or lamotrigine. You've probably heard of most of these: Dilantin, and Tegretol, and Depakote, Keppra, Lamictal. These are all very common medications, and these are what the patient's going to take to prevent them from having a seizure in the future. One thing I'm going to tell you when you're educating patients about these medications, first of all, educate that they must keep taking it. If they stop taking it, they're very high likelihood of getting a seizure again. Even when they do finally stop taking it, if ever, because they might be on this the rest of their life, they are always going to have to slowly taper off of it, not just suddenly stop taking it. So you definitely have to make sure patients are educated to take it as directed and to never miss a dose. Status epilepticus, let's talk about that real quick. That is where a patient has a seizure that is going on more than between 5 and 20 minutes, depending what textbook you look at. I know that's a huge gap, but I've seen it both ways in the textbooks. It might also, in some cases, some books also define it as not necessarily that they have a seizure for the full half hour, but they had one seizure, and before they ever came out of it, they stayed in their postictal phase and went right into the next seizure, and then postictal, and then right into the next seizure. If that's going on also more than the 5 or 20 minutes, very often we'll still consider that patient to be in status epilepticus. That patient, in addition to getting benzos, they're also going to get an IV infusion of usually one of these epilepsy medications, such as phenytoin or levetiracetam. Those are probably the two most common. Additionally, they very often will need to get intubated, especially if the patient's constantly having a seizure. Then the diaphragm is constantly quivering instead of properly working. So that's going to affect their breathing. So we're going to have to put them on a ventilator. Any patient who's having a seizure, big test question is always look for underlying causes. Things such as hyponatremia is a big one. Certain toxins or drugs are big ones, certain medications. If they have a history of epilepsy and they stop taking their medication, but always look for what's causing them to have a seizure today. Next, let's move on to TBI. TBI, or traumatic brain injury, is where the patient gets exactly what that sounds like, a traumatic injury to the brain. Now, when we talk about TBIs in nursing world, there's primary injury and secondary injury. Primary injury is what happened the second the injury took place. Secondary injury is what happened because of that. So let's say they got hit in the head and now they have a TBI, but the secondary injury is, well, because they got hit in the head, they have a bunch of swelling. And because of that swelling, the brain is having secondary complications. So all of that would be a secondary injury. So that's going to be very heavily on us as nurses and the providers to make sure that that doesn't happen to the extent possible. So the secondary injury would be things from like increased intracranial pressure, from cerebral edema, from ischemia to the brain if that happens, from swelling, etc. Presentation would be altered level of consciousness. That's going to be classic for a TBI. It could be other neurological signs and symptoms such as headache, vomiting, amnesia, where they don't remember what happened, confusion, where they're not fully alert and oriented. Pupillary changes would be something that they may present with. Abnormal posturing, such as decerebrate posturing or decorticate posturing. If you are very familiar with GCSs, you should recognize those as being part of it, and other neurological issues. Let's go through a few of the specific presentations. A concussion is where a patient has traumatic brain injury, which, by the way, a concussion is part of a TBI. In fact, most TBIs are concussions because those are the simplest form of a TBI. And a concussion is where the patient has a traumatic brain injury. They have some sort of neurological symptoms, a headache, maybe they lost consciousness, whatever it is, but they are fully back normal within 24 hours. That's a concussion. That's fully reversible with a single concussion technically having no long-term effects. Next, we have a contusion. That's a bruising to the brain. We have DAI. That's gets diffuse axonal injury, and that's where the parts of the brain, they just shear apart. They basically rip. And that's what causes DAI. DAI is a really bad diagnosis to have. Those patients rarely, if ever, have a complete recovery. An epidural bleeding is where the patient has bleeding that goes on between the skull and the dura. And then subdural is where the bleeding goes on under the dura. If you remember the dura that we talked about in the first few minutes of this video. Of these two, there is a classic test question that's often asked. Epidural, the classic presentation, is where the patient has a loss of consciousness. Then they come back out of it. They're fully normal. So let's say they take a bath to the head, they pass out, the standbys wake them up, and then EMS gets there and they seem perfectly fine. But 3 hours later, they're dead. That's a classic presentation of an epidural. Subdural is different. Subdural presents where the patient has, again, that taking the bath to the head, and now they don't necessarily have that acute loss of consciousness or something, but very quickly we start to see signs and symptoms, and they get worse and worse and worse, and that would be the classic subdural presentation. Next, we have intraparenchymal, subarachnoid hemorrhage, intracerebral hemorrhage. These are all bleeding in the brain itself. Next, we have the fact that these are diagnosed by a CAT scan of the head. The head CT, again, we talked about that. That was the very first thing we mentioned in neurology diagnostics, because the head CT is how we diagnose this. In most cases, if they do find something, they're almost always going to follow up with an MRI at some point, probably not during the acute stabilization phase, but at some point during treatment. How do we manage this? Well, that gets way beyond what we're going to talk about. Sometimes it's brain surgery. Sometimes it's making a burr hole to relieve the swelling. One thing that is commonly tested on in nursing school is the fact that if the patient is having cerebral edema, which is swelling on the brain, we may often treat them with hypertonic saline, that's 3% saline, or mannitol, and both of those serve the same purpose as they remove excess fluid and swelling from the brain and bring it out of the skull, and the kidneys would get rid of it, but the point is that it gets it out of the skull to relieve that swelling and to keep the intracranial pressure from getting too high. A few notes, when a patient has a TBI, you may be asked what's considered a mild, moderate, or severe TBI. 8 or less on the GCS is always considered a severe TBI. That's a rule of thumb that's pretty universal. And then the rest of it is a little bit ambiguous. Usually a GCS of 13 or 14 is considered a mild TBI, and then 9 to 12 would be considered moderate, but those numbers are in flux. So it depends what guideline you look at, what textbook your school uses to know exactly what numbers they want. But 8 or less is always going to be that severe TBI. Make sure you're keeping the head of bed elevated. Make sure you're doing seizure precautions because they're at high risk for it. Make sure you're monitoring for diabetes insipidus or SIADH. Those are both fluid issues. One's where the body's holding on to all the fluid. One is where the body's getting rid of all the fluid. So definitely monitor their eyes and nose, because that's a complication that may present in a TBI. Cushing's triad, we talked about that earlier. If the patient develops that, that's a sign of increased intracranial pressure. It's a sign that the patient's heading towards herniation, which would be death. Raccoon eyes is where the patient gets periorbital ecchymosis, where they have bleeding around the eyes, not on the eyes, but around the eye socket, and usually that's bilateral. Battle's sign is where the patient gets ecchymosis, which is bruising behind the ears, and both of those are signs of a basilar skull fracture. One interesting test question that I've seen in a bunch of different test banks is that in a basilar skull fracture, make sure if you have signs of a basilar skull fracture, which would be the raccoon eyes, battle sign, or any direct blunt trauma to the front of the head, do not put a NG tube into the patient because the bones that keep the NG tube from going straight into the brain and instead going down into the gastric like it's supposed to, if they have a basilar skull fracture, those bones may no longer be intact. And now when you put the NG tube into the nose, it just gets wrapped up in the brain. And you can Google, you'll see pictures of NG tubes wrapped up in the brain because of exactly that. And then finally, the CSF leak sign, that's in most textbooks, it's called the halo sign. That's a little bit of an older term now, but it's where you take a gauze, and if you have any fluid leaking out of the nose, any fluid or blood leaking out of the nose or ears of a patient that has a head trauma, you take a gauze and you just touch it to that. You get 1 drop of fluid on your gauze, and you look to see a positive halo sign or positive CSF sign is where that dot becomes outside ring of a yellowish fluid and an inside ring of the blood. The yellowish sort of separates out. That's usually the sugar. And that's a sign that that dot that you got on your gauze that leaked out of the nose or the eyes, that those are actually contain CSF, cerebrospinal fluid, which means it's not just blood, which means that the patient has actual injury to the, or some sort of traumatic injury to the brain itself to have CSF leaking out. Next, let's talk about meningitis. We're almost at the end. Meningitis, the pathophysiology is inflammation of the meninges. That is self-explanatory. This can be bacterial or viral. The presentation here is a fever, sometimes very high, sometimes minimal, depending. Nuchal rigidity, that's by far the most tested on point about meningitis, is nuchal rigidity is where they have a stiff neck and they cannot lower their neck or it's really going to hurt them. Headache, photophobia, meaning that they don't want the lights on, vomiting, altered mental status, or certain types of rash. Positive Kernig sign, that's where they have pain on leg extension, or Brudzinski sign is where I lean their neck forward, and that leads them to pull their knee in as a reflex. So those are both signs that the patient has meningitis. By far, the most tested on is that nuchal rigidity. If you see that in a test question, always pushing you towards meningitis. Meningitis is diagnosed by an LP, a lumbar puncture. Lumbar puncture, you probably don't have to know this, but if you do, the lumbar puncture is positive for meningitis if they have a high white cell count, a low glucose, and a high protein count. We would also do blood cultures to check what infections are in their blood, and we'd also do a CT MRI again because it's a neurological issue. Management of meningitis is IV antibiotics as well as supportive measures. It's interesting to note that any patient who is diagnosed with meningitis is also their close contacts. Anyone who's been in close contact with them, whether that's a school, it could be the entire football team or the entire class, is all going to get prophylactically treated. Generally, that's with ciprofloxacin. In fact, that's one of the drugs, antibiotics, that the government keeps hundreds of millions of doses stockpiled for exactly this reason. If the patient is diagnosed with meningitis, initiate droplet isolation. So that's a big test question. You should educate the patient on prevention through vaccination. That's the last disease that I have. I do want to also mention that in some med-surg courses, you're also going to learn about the neurodegenerative diseases. Those include Alzheimer's disease, Parkinson's disease, multiple sclerosis, and myasthenia gravis. I didn't cover those here because A, sometimes those are not covered in neuro, and B, those don't have a lot of test questions that we have about that. They don't have the high nursing priorities about isolation or respiratory or neuro checks. Those are just some of the more less comprehensive diseases as far as what's covered in a med-surg course, so I didn't include it in this video. If you have any questions, please reach out to us. Hopefully you enjoy this and it helps you on your class or the NCLEX, and we will see you in the next video. Have a great day.